this session aims to present a taster of some of the draft findings, but generally facilitate a discussion on generally talking about developments at national level from the CNIO team. So we'll be hearing from our panel individually in a moment, then we're going to have a group discussion, and then I'll open it up to you, our audience, to ask questions as ever, but feel free to start putting your questions in the chat box during the discussion when you think of them. So as I said, in a moment I'm going to introduce our panel and invite them to speak, but I'll first tell you who they are. So we have Helen Balsden, so Interim Chief Nursing Officer, Information Officer, sorry, NHS England, who you've just been listening to, and we've also got Sam Neville, who's Regional CNIO Eastern, and also CNIO MSE Hospitals Group, and Professor Gemma Stacey, who is Deputy Chief Executive Officer and Director of F&F Policy Unit at the Florence Nightingale Foundation. So I'll just introduce them. So we've heard from Helen already. So Sam, do you want to go first and just give us a quick word?
Good morning, everybody. Yeah, I'm Sam Neville, CNIO and also Clinical Safety Officer. I was one of the Phillips Ives Fellows that worked on the Phillips Ives Review at the time and worked on the AI section. Huge learning curve, still learning. But it's good to be here today. Thank you.
Right, and Gemma.
Hey everybody, thank you for the invitation to join you. I am Professor Gemma Stacey. I'm the Deputy Chief Exec at the Florence Nightingale Foundation, and I led the person-centred practice panel of the Phillips Ives Review. So really looking forward to sharing with you some of the learning that we gathered around how digital and data can enable person-centred practice. And we had some really astoundingly excellent examples of where that's been put into practice, and we're seeing great results already, but also some of the challenges that we are already grappling with and those that are in the future ahead of us, and our suggestions as to how we can navigate through those.
Great, thank you, Gemma. And Helen, last but not least.
Indeed, thank you very much for inviting me back. I'm Helen Balsden, the Interim Chief Nursing Information Officer at NHS England. My focus with the Phillips Ives is really taking it to that next level, wanting to get it published and out there so we can share the amazing work, but also then looking at delivery. What does that look like, and how do we move this amazing work forward to really make sure that we've got the foundations in place and we can build so that nurses and midwives can truly harness technology and data and everything that's digital to move our profession forward and start addressing some of those many challenges and create new opportunities, new ways of working.
Perfect. Right, thank you, everyone. Okay, yes, so as I said, we've now got some time for discussion before we go to Q&A with the audience later on. I suppose I'll start with you, Helen. I guess you mentioned that obviously the review hasn't been published yet, but we had some draft recommendations, I think, didn't we, that we were looking at last year. Could you just give us a quick précis of give us sort of the 5 key things you think will be in it, and is there a timeline basically? Is it like when can we expect to see it?
I'm hoping it'll come out before the end of the year. It is in our publication approval process, so all fingers crossed that it'll be in the autumn. But I am bound by those issues. So yeah, the headlines, I think we're really going to see some focus on the role of the Chief Nursing Information Officer. What is it? We know we've got huge variation across England, and we know that what was really called for was to standardise, create the career pathway, support that with the right education and training. So that's absolutely there. We're also looking at what our pre-registration students might need, but also recognising that it's not just about pre-reg, and there's lots of asks about what our students might go for, but also how they learn, something about how we support our health education institutions to support ways of working in a digital world as opposed to analogue. And we have had number of conversations about that. We know that they're very much up for change, really wanting to make sure that we've got dummy EPRs or something equivalent within the training setting, and we make it easy for our students to learn that way, because paper is disappearing at a fast rate of knots. It's about how we support the education institutions as well to develop that and grow them. Many of them will not have worked in a digital landscape, so we need to support them to develop their skills so they feel comfortable and confident. And also post-registration, really looking at how do we equip nurses to have the skills to use all things digital and all things data, recognising that's all changing at a rate of knots. I think as nurses, we're very used to collecting data, and we're not necessarily so used to analysing or interpreting. So it's looking at skills in data science and how we use that, but also where could AI help our practice? What do we need to know to enable to harness that as a profession and move things forward? So some great exciting stuff in there.
Perfect. Thank you, Helen. So, Gemma, putting you on the spot slightly, you mentioned patient-centred services, which obviously is a very, absolutely fundamental thing, particularly in modern healthcare. Could you just explain to us from your work on the review how we're going to maintain the patient-centric approach while incorporating the technology into healthcare practices?
Absolutely. I mean, we heard some of the best international examples of where technology has been an enabler to changing the dynamic between the healthcare professional and the person receiving care. And by that, what I mean is that the person has access to information about their own health, and the healthcare professional has a role rather than prescribing or directing them in terms of their options. They are much more about helping the person to understand what that means for them individually in their own circumstances, within their own community and family setting. And so they became more like navigators and interpreters of this information. And the decisions that came from that were genuinely shared and collaborative. And so the power dynamics completely changed when we saw that kind of relational difference. And the other areas that we saw real positive benefits were around reaching groups who have typically been challenging to enable access to different types of information and healthcare interventions. There was a wonderful example that's a case study in the Philips Ives review of a service in Norway that was delivered via telehealth to people with long-term mental health problems. And that was around their cardiovascular health, their diet, and other areas that were related to longer-term conditions. And what they saw was significant changes in the outcomes for those individuals, because they had different ways of accessing the information and the support from healthcare services. So we can really see that the whole way in which we engage and we interact will be very different with these tools and with access to this data. I think the other thing that we heard as well was how efficiency can be improved. So rather than information being collected numerous times, having the right information to inform decisions, the clinicians were finding that their time that they had was more meaningful. So rather than collecting the same information again and spending that precious interaction time with the people they were caring for on that, they were able to use the information available to them to start to really have more meaningful and in-depth conversations and interactions. So the satisfaction that they gained from that work was significantly more. So the real kind of job satisfaction, the feeling that they were making a difference, that they were really enabling that person to take steps forward in their health was so positive to hear. And that's really relevant for us now, obviously, because we need to think about ways in which we can ensure that every single moment that we have in contact with the people we care for is meaningful and has a positive impact on their experience and then their future outcomes, particularly because of the workforce challenges that we're encountering currently. So that joy of work is so important, and using our precious resource to its absolute best ability, really enabled by some of these digital tools.
Great, thank you, Gemma. Yeah, really interesting. Sam, if I can turn to you now. Basically, I know Helen's already mentioned it a little bit about the sort of education and training side, but just based on your experience, basically, how do we equip the workforce, so both nursing and midwifery, with the competencies that we require, basically to, I suppose, thrive in the digital era. Basically, how do we get everyone on board, I suppose, and give them the right skills?
Yeah, I think the first way of starting is trying to show the consequences of what we do with digital. So having people understand that it's record keeping, again, we're going back to this national standard that's just come out, is the same on digital as it is on paper. It's just as relevant. And I think it's getting staff to understand that. It's also getting staff to understand the myths behind some of the technology. I mean, when we was looking at the AI section of the Philips Eyes, it was obvious that staff didn't really understand what algorithms and AIs they were working with already. And a lot of it is already out there in healthcare. And we just need to understand it better. And we need to bust those myths to say it's working and it's relevant and it's safe as well. There is lots happening at the moment in technology, especially around AI. And with a clinical safety hat on, we need to make sure it's ethically correct and it is safe to use. So it's not just going gung-ho and throwing technology at staff nowadays. It's getting staff to work with you to implement them. So they feel the ownership and they have the understanding of what's behind it, rather than just that they've got to input some data into it. It's not just the pre-reg and the new post-reg, it's also the workforce that we've already got in place at the moment. There's people like me, 50 plus, not used technology when we were youngsters, and it's a new thing and it can be scary. And it's just hand holding some of these people and showing them it's not as scary as it looks. It's not going to bite you. And we can make it work, but it's making it user friendly. So whatever system we look at and whatever, look at the usability and make sure it's intuitive for staff to understand. And it's not just about going off to educational places, it's shadowing staff. Get people to come and follow the CNIOs or the technical and have an understanding. There's lots of webinars, there's lots of conferences like this one we're doing now that they can just join in with. So it's not all doing a course. A lot of it is getting out there and just looking to see what's happening.
Great, thank you. Because you mentioned it, I'm going to stick with you, Sam. But I suppose those all sound absolutely like the spot on for the approaches on getting people on board. But I'm just interested. Do you think there's been a change in attitude at all? Do you think we've started to win the battle? I suppose if it's a battle, not really a battle, but a campaign maybe for hearts and minds in terms of technology. Do you think people are more willing of all experience levels, I guess, to engage with it?
I think it's slowly turned, definitely. I remember when I first qualified and technology was very scary. Nobody wanted to know. But nowadays we've got people coming and asking us for new technology, new ways of working. We've got the new standards coming out as well, which helps back us up nationally. So I've had a lot of staff come and say, can we follow you? Can we come and do a placement? So I think the tide is turning. It's time. But I think this year, next year is probably the time for digital and technology within healthcare. And it's more nursing and midwifery now that are coming to us. Before, it was a lot of doctors with diagnostics and that sort of thing. But now nursing and midwifery are understanding the benefits more, and especially when the data. So they're looking at their dashboards, they're looking at the improvements they can make and asking how they can get that data better.
That's certainly sort of sort of chimes with what we hear when we speak to people, that there's definitely within nursing and midwifery a real bit of a step change really in terms of uptake, from it just being a very small group of people that we always knew were interested, sort of enthusiasts, to being much broader now. So which is really positive. Gemma, I suppose as working at the FNF, do you from a slightly outside the CNIO situation, do you observe the same sort of trends?
Yeah, absolutely. We held a symposium a few weeks ago with the members of the FNF Academy, who are all senior nurses from across the UK, working in every setting and sector. And one of our discussion points was around the prospect of digital for the profession and how they perceived the challenges and the opportunities. And there was an overriding sense that this represents a significant transformational opportunity for professions, and there was real commitment to being at the heart of driving that change. So rather than being the recipients of structural and technological changes that were imposed on them, there was a real sense of drive to be right at the heart of those and making sure that they were fit for purpose, that they were going to enhance their roles and ultimately the care they were able to provide within their various different settings and sectors. I think that there was also that sense of scepticism and concern, rightly so. So people have felt that they've got behind different technologies previously and they haven't delivered what's been promised. And also there's a real challenge around the access to hardware. So making sure that we have the right kind of equipment to be able to utilise the best technologies and softwares. The biggest challenge, I think, particularly in England, was around the integration of systems and knowing that different health and care environments are adopting different systems, have access to different standards of technology, and a real concern about how we were going to take that forward in a joint up way. But all of those things were identified as the challenges, the problems that we need to tackle, rather than being seen as the blocks that would mean this wouldn't happen. And there was certainly a sense that this is inevitable, that this is the wave of transformation that is happening and needs to happen. So what I took away was that's probably what's the shift, is that they want to be right at the heart and the drivers of it, rather than the passive recipients of.
Thanks, Gemma. Great answer. Yeah, again, that absolutely chimes with what we've heard at Nursing Times. Just involving people in the well, not only the implementation but even in the design is just really fundamental in getting people. Getting people involved, but also getting a system that does what nurses and midwives need or want, basically, I think. Great, thank you. So, Helen, I'll turn to you now. I know you've already mentioned it, but I think it's already been mentioned a couple of times. It's hard not to mention it at the moment, really, but AI is obviously everywhere. I've been on a steep learning curve. I didn't quite understand how it worked, and now over the last few weeks, I've much more of an understanding, shall we say, because we've been experimenting with a few bits and pieces at Nursing Times as well, just to see how it works. And Chat GPT, which is obviously nothing to do with GPs, which I did at one stage think when I first heard it. But anyway, obviously, so lots going on. So I suppose it's a bit of an open-ended question, is it? But what's the realistic potential for AI? Do you think, in terms of I'm not going to use the word revolutionise, but supporting nursing and midwifery, do you think?
I think the honest answer is I don't think we know that yet. From certainly the literature and the evidence, there's a lot of AI being used in research and at early stages in its development, but not a lot of it has made it into mainstream nursing care and the way we record, the way we use it. We're seeing a lot of things like clinical decision support tools, but not necessarily AI. I think the next one we'll see is predictive analytics. And how does that help us? Because where we are seeing that they're at really good use is things like falls management, deteriorating patient. And I think it's those areas that we see the potential, but we haven't mainstreamed anything yet. And I think as well, it's a lot of people telling nurses where AI could make a difference, but I don't think it's many nurses telling nurses where it could make a difference. And so, I'm delighted that, we might have got the opportunity to develop some AI fellowships as part of the broader Digital Academy work in some of the areas, because I think getting some nurses or midwives to understand more about AI will really help us go, and what can we do? We're as a national team having conversations about who's already using it and where are they using it and what can we learn from some of that. So I think a lot more to come to understand what people have got. And some of that variation is very much due to the fact that digital maturity across the NHS in England is very variable. And some organisations still on paper, but luckily only a handful. But the group in the middle that are not very digitally mature, but they're not digitally mature, have also really wide variation with some bits digital, some bits not. So we're grappling with all of that. So it's the landscape in which we work. So I think lots of questions more than answers at the moment.
Inevitably, yeah. Lots of nodding as well. Sam and Gemma, did you have anything to add on AI?
Only to agree with Helen from the roundtables that we did as part of Phillips Ives review. It was obvious people were interested. They were curious on what it could do, but again, it raised more questions. There's lots of examples around diagnostics with X-rays being checked by AI and CT scans, but nothing other than algorithms really. And like you say, predictive analytics for nursing and midwifery. It's whether or not we look at extending that and how to. We've got things like the speech recognition that we can start using for dictation and ambient technology that we can use, but it's not embedded, it's not really trialled properly in a nursing midwifery environment yet. And I think that's where we need to go next. Get some use
Steve,
cases.
Could I add one more thing?
Yeah, absolutely. Yeah.
Because Sam's just made me realise the fundamental that good AI takes is those really good algorithms. And that means we've got to do that cultural shift in care. So you will know we've published the unified approach towards nursing and midwifery documentation in the last month. And that really starts to ask nurses to consider moving from long narrative to structured data. Because structured data is easier for technologies, one, to extract, to give us good data, but also to build algorithms from. And unless we've got that core platform, we may not be able to harness all of the AI and the technology that's coming down the line.
Yeah, I guess that's the thing. Possibly sometimes people don't necessarily realize that obviously AI basically it can only be as good as the information and the data that it's trawling via algorithms. Yeah. It's not some kind of
absolutely
coming up with stuff from nowhere. Yeah. Great. Gemma, did you have anything to add on AI, or have we covered it all?
There was just I guess again around the person-centred practice element, there was certainly some fears around the potential for AI to replace or de-skill nurses and midwives in terms of their clinical decision making. That it could become a substitute for what is, a very human judgment that is required when you're in the moment, in that relational interaction with the person that you're caring for. And one of the things that we identified through the review was that we have a responsibility as professionals to be guardians of that. So to really learn about AI so that we can ensure that its implementation is wholly ethical and that it's used for the purposes that enable our clinical practice and our judgment. And also be aware that we will have a generation of nurses and midwives who will have been used to AI and computer-assisted decision-making being the norm. So they won't have necessarily built confidence in their own clinical judgment without those tools. And so just being really cognizant of what that means and what those professionals will require, what they can teach us, but also what support they may need in developing that confidence. So I guess my word of warning really is that, or ask to the professions, particularly people like Sam and Helen who are leading this agenda, is that they are always keeping that the ethics at the heart, and I'm totally convinced that is the case, and that we provide that reassurance really to the wider profession.
Yeah, I mean, there's as you say, lots of excitement around AI, but obviously certainly healthy caution as well, I think, amongst obviously professions that are very much based on evidence and data and things like that. Helen or Sam, did you want to come back at all on what Gemma had said there?
Other than, I guess we've got to bear in mind that AI is just one tool, and it is about how do we harness it, but it only works in certain places. From my own learning, which I will say I've still got lots to learn as well, as we're all learning this journey, it often works in very high volume areas where there's data and repetitive tasks, and actually doesn't always consider some of those nuances about individual care. So we've really got to think about where and why and how will it impact the profession, so that we really do maintain that professional decision making, because that's at its key. We're registered practitioners and are highly skilled. These digital tools are only to enhance what we do and to make some of those highly repetitive tasks easier and probably more consistent, but they are niche. They are not the whole of what we do, they're just a part.
Absolutely. Great. Thank you, Helen. I'm going to stick with you and just change tack slightly. Obviously, we were talking about I think you were talking towards the start around the number of regional CNIOs and things like that we've got in place now. Feels like we've got a really strong digital nursing community out there. Very enthusiastic and really innovative group of people now who are increasingly meeting and discussing things. Do you think that's that group is now secure? You've got your regional leaders all sort of cemented in place now, that we're going to move forward, I guess, and there's no chance of it all disintegrating a future date if depending on governments, other things like that.
I think there's still work to do. So Ruth May called out a couple of years ago that every provider organisation should have a CNIO. I don't think we're there yet. I think we've still got some work to do, especially outside of hospitals. We hear from the CNIO that digitisation in community is very high, but it's not necessarily fit for the purpose of community nursing. We know that CNIOs in mental health, there are people, but there are few and far between. And again, it's an add-on to what people do rather than nurses driving it. So I think we've come a long way. And I know our most recent data, it's not 100% of a data set, but certainly it suggested a 20% increase in the number of organisations with the CNIO, but that only sat at around 80%. So I to go to move that forward. What we also see is huge variation in the bandings, the remit and the function of those roles, which is why I think that work that we called out at the Phillips Eyes Review in terms of taking a look, what actually is it? We picked this title up from the States many years ago, brought it over. We've done amazing things. The CNIOs we've got out there have carved this new landscape. But how do we make that solidify and really set the pace for the next 10, 20 years so that technology and digital, whatever that might look like, is absolutely mainstreamed, moving forward, but nurses driving it so that these systems, work for us and enable us to be the best we can be.
Great, thank you, Helen. You mentioned the community settings, things like that. Obviously, we've got virtual wards and things, and obviously we tend to hear quite a lot about hospitals and community. I think possibly fair to say. Mental health was interesting that you mentioned. I hadn't really heard about its use in mental health. But are there any particularly exciting innovations going on in other settings or parts of nursing that you're aware of? Could be social care or anything really.
Really good question. I think there's lots of exciting stuff going on in social care. Again, I don't hear lots about, but looking at some of their they're really well designed. They're designed for people to have a look at. So caregivers as well as families. Site, so really visible, and you can look at data in lots of different ways there. I think some of the mental health stuff that we're seeing is really looking at how do we use some of those digital tools differently that might redesign clinical pathways. I think mental health in particular, and Gemma as a mental health practitioner by background might be able to comment more, but really using that patient-centered design, portals, so that there's two-way communication, really driving some of that forward. I think hospitals have still got a lot to learn from some of the mental health. Again, they're very well digitized, but the nursing roles within there are not quite so prolific. But there's new emerging technologies. We talk about ambient technology, and I've seen some really exciting stuff that isn't just about voice, that's about thermal, that's about actually being able to see where the person is in a room before you enter it, without actually seeing the person. You might actually see a few dots. It's not breaching their privacy, dignity, or any of those government rules. But in a mental health setting, some of that might be really important to know and see before you enter a room in a high secure unit where somebody's, really distressed and you don't know what's going to happen as a professional when you walk in there. So really different ways in which we can harness technology to make it safer and actually give really effective care.
Great, thank you, Helen. Gemma, with your mental health hat, did you have any examples, or it didn't have to be mental health, of course, but any examples the FNF were aware of?
What Helen just described there is a project that one of our digital scholars is currently undertaking in a high secure setting, and the real benefit of that is that person actually does have privacy and dignity because they don't have to have people observing them constantly. They're able to have the privacy of their own space and therefore feel less restricted in the way that they're being cared for. So there are some really, really excellent examples also about just offering that flexibility to the way in which we communicate that we haven't been able to offer before, and sometimes requiring people to come into clinical spaces who experience mental health problems. It medicalizes their issues. It feels an inappropriate setting for them to be seeking support. Whereas some of the digital tools are allowing people to access support in different ways when it's actually needed and on their own terms as well. So much, much more empowering. One of the other areas that I was really impressed by is the potential of data to inform our public health interventions. So I think we've spoken a lot so far around how we treat people who are unwell within our services, but digital offers such a huge opportunity for us to really tailor our public health interventions to the specific needs of a particular community or demographic, where there's certain trends. And really what the terminology I heard a lot was about democratizing knowledge. So rather than the information staying with the healthcare professionals for them to impart on people who they either educated or treated, that actually this information can be out there in a manner that is accessible, that people can use and implement and integrate into their own lives and make those changes to their way that they live and take care of their own health as a result of that. So there's some great examples where people are entering their own data so that we can get a real sense of trends within different patterns of disease, and also accessing information that wouldn't have normally been available unless they had contact with a healthcare professional.
Great, perfect. Right, we've had a few questions in, I'm really pleased to say, so I'm going to now move to asking some of those. So we've got about just over 10 minutes left, 12 minutes left, something like that. So I'll try and get through as many questions as we can. Right, so the first one is directed at you, Helen, and it is on structured data. So Zach Whitehead Moores asks, great to hear structured data featured, Helen. But it would be great to get some specifics around the type of content required, e.g., I may get this wrong, SNOMED or SNOMED so that learning and implementations can be as efficient as possible. At present, there is a lot of duplication of effort in different organisations. So structured data, basically.
Absolutely, and we've started that journey with the unified approach to nursing and midwifery documentation, seeking that cultural shift and that shift away from long narrative to structured data as under then. But actually then it's about how do we underpin that and move it around the system. Zach's slightly biased in his role. He's a terminology background, so he knows this. And SNOMED is the standard that we use in the NHS. So absolutely. We're doing a further piece of work with the Professional Standards Record Body, and they're working with the terminology team to look at if we created a standardized terminology or use standardized terminology for nursing, what would that look like? And how do we use it? So we're coming up with an information standard, and I hope that some of that will start going into the public domain in the next couple of months as we start publishing drafts. We're going to the point of, we've done lots of consultation with different groups at the moment, and certainly we have the level of nursing engagement to some of the webinars as we work through what data would we collect and what's meaningful to share around the system. And we've started with some of those fundamentals of care, mobility, nutrition, hydration, washing and dressing. It's just the starting place, but how do we capture that data? What's the code that goes with it, and how do we share it across the systems? We are on a journey. This is not a quick win, and not all the systems have got the ability to share information. But starting this journey means that we can do that together, work out what works, what doesn't work, and refine and build on that story as we move forward. And that structured data piece and the standardized terminology is really important because we all do something different but the same. So when we were looking at nursing documentation, we found at least 3 different ways in which you could assess somebody for skin integrity or risk of deterioration. Now, if you don't know that particular tool, I use Waterloo or Purpose T, Anderson were the 3 we found, you're not familiar with that, you might go, well, I don't know that, so I'll just do my assessment all over again. Whereas if we could share information that might be more specific using the code, so that actually we just go, this person's at high risk of skin deterioration. Actually, do we need to know more? And please, we're still working this through, but that in itself would help us go, right, they're at high risk. Let's not waste time reassessing. Let's get them on a pressure relieving mattress ASAP. So if we could make that transition and really start harnessing data, we might be able to give smarter care that's safer, much quicker, and move that around. But we've got a long way to go before we get there. But it starts with those data standards and actually then trying to bring them to life and work through how we work, how we share that information, and how we use. There are some cultural issues in amongst all of that, always. So we don't always, as nurses, trust the information that other nurses give us. So we think we have to redocument all over again. So that's going to take time to get used to, is it a different way? But also, I think it's not clear cut as well. Just because somebody's had an assessment, maybe in community, before going to accident emergency, you've still got to make a judgment about, if I've got that data, am I able to use it? And I think that comes down to a clinical decision, because if it was assessed in the last few weeks, you'd probably go, that's probably fairly accurate. But if it was the last assessment was 2 years ago, you might go, actually, it's safer to reassess. It's not clear cut. It still requires clinical decision making to make the best decisions to look after a person safely and most efficiently. But we're on a journey.
Yeah, absolutely. Yeah. Obviously, documentation has actually proved to be a popular one, actually. But Sharon Hunt, she's put the documentation stuff together with AI. So she said, historically, nursing documentation has taken the lead from innovative practice from countries such as the US. I appreciate that the healthcare landscape is a different entity there. However, are there lessons to be learned regarding the introduction of AI in nursing? And obviously interested in AI because she also asked another question, which was, will you be publishing your evidence on AI in current practice on the NHS Futures platform? So I'll take those two together. So I guess
shall I start, and then
sorry.
Sam may want to? Yeah. Yes, we are planning to publish the evidence. We are planning to publish a findings report that summarises those, and we're currently planning to publish the evidence on our Futures site, and there may be other routes that we use as well. So we've done this work, and we want to put it into the public domain. Because it's really important. So yes, lots to come, and we'll share that loud and wide once we've actually got those decisions about what we do and where. In terms of that US piece and the learning, I'm actually, one of the things that I really enjoy and are very privileged to be part of is an international group of nurse leaders that look at a broad range of topics across nursing informatics. And I work with some amazing people. And we actually met 2 weeks ago, and we were discussing AI in nursing. What was really clear is no country, including the US, has got this sorted. In fact, there was a recent publication, I think it was in the New England Journal of Medicine, looking at AI in the US, in health systems, what did they got? And there's a lot about cost payments and reimbursement, but only a small amount in operational processes and quality and safety issues. So I think this shows that it's still very early days internationally, especially in countries that are probably far more advanced digitally than we are. So we're not far behind, but there's still so much unknowns.
Great. Sam, did you have anything to add at all? Has Helen all covered it all perfectly?
I think Helen's covered it quite perfectly, but just to say, a lot of the AI resolves around integration as well. So integration of systems to allow the data to flow. And that's some of the challenges we've got at the moment with the disparity of systems that we have across healthcare. So a step at a time. And like Helen says, it's a journey.
Yeah. Sort of similar theme, I suppose, around, as you say, it's a journey. Stephen Boyle has highlighted, he says, I understand the potential value in using technology and investing in skills needed in nursing to exploit that technology, but what can we do to remove the real world barriers to using technology on the ground? Examples being access and investment into devices, having the right number of them and at the right specification, access to wireless and connectivity, and the need for, multiple usernames and passwords. I'm sure we can all relate to that. So the various barriers, I suppose, to technology in terms of just the practical things that we come across every day in terms of, Wi-Fi and things like that. Is that something you've come across, Sam, in regionally and nationally, I suppose?
Yeah, it is. It's definitely a challenge, and I think this is where the network of nurses, digital nurses and midwives come in, because they're the users on the ground. They identify where the concerns are, and they liaise with technical teams to find solutions. So it's making sure it's the usability again, making sure we've got the system, but we've also got the kit and the access to use that system. And it's difficult. The CNIO report did show that most of the nurses were digitally aware, but it was the access to stuff that they had a problem with. So that is being worked on, and it's for the regional leads to pick up with the ICBs and the areas as well to say this is what we need in the area, in each area. My area, Eastern Region, is quite geographically spread and it's quite rural. So you can imagine some of the concerns. So we've invested in dongles, 4G, 5G, as well as the Wi-Fi. So there are ways around things, but it's getting the terminology correct. Not just saying, I can't access it. We need to find out why people can't access it. What is the problem? Is it a password? Is it the Wi-Fi? Or is it the actual kit itself? Or is it the system? There's multiple issues. So the digital nursing midwifery teams are the ones that can pick up these issues and just liaise and translate for you.
Thank you, Sam. Anything from anyone else to add on access to well, barriers and things like that?
I would just like to come in. I would like to come in if I can, please, Steve. I think these are things that have come through that National Digital Maturity Assessment, Wi-Fi in particular. They're issues that need to challenge. It's all very well putting software in, which is the EPRs, but actually you need the infrastructure and the hardware to be able to support. And actually what you're trying to do with some of that is make it easy to document the right care at the right time in the right place. And that requires different solutions. So what a community midwife might need is different from a ward-based nurse. So you have to consider all eventualities. And the functionality of our software, for example, might be actually, have you got an offline functionality that would enable you to upload data if you are in a rural area, if you're out the hospital, but also, you know, what do I need at the bedside and what's the task that I'm doing? It's very hard to use a small handheld device to see real complex medication charts. You might be better on a bigger computer so that you can see the whole. And they're factors that all need to be considering when we're looking at the right hardware for the right task at the right time. So it's a complex piece. I think in my previous role at Cambridge University Hospitals, it took us several years to get this right. Really looking at where mobile hardware was used, how we were going to use it. And we also need to recognise that actually footprints of clinical areas are not the same. I had 56 inpatient wards and I don't think any of them had the same floor print. So how do you manage medication management? So you end up looking at mapping clinical pathways, tasks, and then going, so what's the equipment and how is the equipment used and how is the software configured to enable that workflow to work? So really you have to bring together people, technology and the process to make sure that you've got the right solutions for software and hardware.
That's a great place to stop because I'm afraid we've run out of time for our first session. So thank you very much to our brilliant panel. Helen, Sam and Gemma covered so much ground there. Really, really interesting stuff. We've now got a short break and we're going to be back again in about 10:15 when we're going to be hearing about using mobile technology to transform frontline staff engagement. Thank you very much.